right, a warm welcome from Geneva, Switzerland. In 1 minute and 35 seconds, we'll be starting this lightning chat, part of a series ahead of Teach to Reach 10 on 20th and 21st of June 2024. And today we're going to be coming together with an old friend of Teach to Reach, of course, an advocate globally of immunization for every child to be protected from vaccine-preventable diseases, for every family to be protected, and for no one to be left behind. That is Kate O'Brien, who leads the Department of Immunization, Vaccines and Biologicals at WHO. So warm welcome to Kate. We're starting in 1 minute. And of course, with me is, two-thirds or 1/3 of the trio, which is Charlotte and Boo. Charlotte, warm welcome. We've been working together, hosting these lightning chats and many other things together. We now have Maria Monzon, who's joined us. How are you doing?
I'm doing great, Reda, and really looking forward to this interview with Kate after 3.5 years.
All right, wonderful. Okay, 30 seconds left in the room with us. We have some of the guests of honor from Teach to Reach 10. So these are health professionals from all over the world who've taken the time to share their experience around climate change, immunization, but also malaria, neglected tropical diseases, digital health in the weeks preceding Teach to Reach. And so we've invited them to be here with us in the Zoom studio. If you're watching online on social media, we're also live streaming across YouTube, Facebook, Twitter, X, and a few others. So wherever you may be, a warm welcome to you as well. And here we go. We're starting this lightning chat with Kate O'Brien. A warm welcome, Kate, to Teach to Reach. This is not the first time you are joining us. We interviewed you in January 2021. That was, of course, a momentous time for everyone working in immunization. We have a set of questions, and Charlotte is going to kick off the very first one. Charlotte?
Thank you, Reda, and good to connect again, Kate. So on the 20th and the 21st of June this year, immunization staff from all over the world will gather to meet, network, and learn from each other at Teach to Reach 10. One in 5 of them work in armed conflict, half of them are government staff, half are from civil society organizations. Over 80% of them work in district and local communities. What message will you like to convey to them as they continue their critical work in the face of both long-standing and emerging global health challenges, including those related to climate change?
Oh, thanks so much, Charlotte, and what a pleasure to be with you. And what an honor, actually, to get this question, some ability for me to speak directly to those of you who are on the front line. So what I really most want to say is the rest of us are working in support of you. Your work is the direct boots on the ground, frontline work, and we all honor you and are in awe of what you do. Immunization continues to be a tool that is at the forefront of improving health in every community that you work in, and especially in low-income countries, and especially in the fragile contexts that are in some of those countries. And I mostly want to say just what a privilege it is to be able to be in the room with you. And we send you our just absolute support and deepest respect for what you do every single day, and full recognition that you are where the action happens. And we're listening carefully, really carefully, about what you most need from us to be able to do your work more impactfully and more effectively. So I just want to express the honor that it is
Thank you very much indeed, Kate. So we have a follow-up question to that one, which is the following: is what would you say to a Minister of Health who hears that health workers working for the EPI team from her country are joining this Teach to Reach global event, are sharing their experience? Is this a good use of their time? Why or why not? Is this something that they should be doing as health staff, sharing their experience in an open global forum such as Teach to Reach?
So this is actually a critical thing for health workers to be doing. And if any ministers are listening to this, we're completely supportive of these kinds of fora. Where learning really happens and where best practices happen is just by the innovation that people on the ground actually, their brilliant ideas about what might work and trying it. And the only way that that goes to scale is by actually sharing it with other people. So 3 things that we think are of huge benefit is, number 1, sharing the good practices that you've developed. Second is building connections, because none of us operate alone, and many of you are operating under really difficult circumstances, so building those connections. And then thirdly is gaining new knowledge. So hearing those great ideas that are coming from some of your peers and really taking it back to where you're working and trying some of them to see if they will work in your setting. So 3 major things: sharing good practice, making good connections, and gaining new knowledge. Super critical.
All right. So, Charlotte, with question number 3, and on your screen, you can see "Humanly Possible," the slogan for the 50th anniversary of EPI. Charlotte, what's your question about that?
Kate, as we celebrate the 50th anniversary of EPI, what do you consider to be the program's most significant achievements, and how have these successes shaped the current landscape of global immunization efforts?
50 years of the EPI program has resulted in over 154 million lives saved. I know that's a huge number. It's sort of hard to get any context on it. But what I think we can translate it into is, first of all, probably every one of us who are on this participation event have been touched in some way by vaccines. Secondly, measles vaccination accounts for about 60% of those lives saved. It is a huge contributor to saving lives. And when we think about it a little bit differently, these 50 years of the EPI program have contributed hugely to the reduction in infant mortality and child mortality. Of all of the reductions that have happened, about 40% of that is actually a result of the EPI program. So those are sort of the big things that we're celebrating, and there's more value on the table. So there's more to do in the next year, in the next 5 years, and certainly in the next 50 years.
This isn't on the list of questions we had prepared, but I have to ask, Kate, I know you're a pediatrician, so you obviously care about children, but I'd like to hear, in your career, can you think of a situation, can you think of a moment where you realized how powerful vaccination could be, how much of a difference it could make, and this slogan, "Humanly Possible," was really brought to life through something that you personally experienced?
Sure. You know, earlier in my career, quite a bit earlier in my career, I worked in the a slum area of the capital city of the country of Haiti, and I worked in a hospital, made ward rounds every single day, and the vast majority of kids who were in the hospital, and 30% of them didn't leave the hospital. There was about a 30% mortality rate for admissions to that hospital. But the vast majority of them were suffering illnesses that were vaccine preventable. And it was the grief of a parent at the passing of a child is the same everywhere I've worked in the world. It's absolutely crushing and heartbreaking. And the fact that those kids absolutely did not have to pass from the diseases that they had was a really marking moment for me, and really turned my career towards working on vaccines. And the second I would just point to is that I worked for many years with American Indian populations in North America, and the power of vaccines and the power of those communities to participate in building evidence around what vaccines would be most effective in their community. And it was the leadership of the tribal members that actually drove the value of the work that was done there. And those communities now have a totally different survival of children and protection against vaccine preventable diseases. So those are two of the things that I think were really impactful for me that brought total life to what it means to be humanly possible.
Thank you, Kate. Now we do have, let me just share a couple of the comments coming in. So first of all, in our Zoom studio is Nduka Ozor, who says in northern Nigeria, so Nduka is diving into the climate change topic where we work. Climate change exacerbates droughts and floods, intensifies food security displacement. Concurrently, low immunization rates driven by conflict, misinformation, poor infrastructure, fuel disease outbreaks. Together, these crises threaten public health and livelihoods. We're going to come back to that, and Duka will come to you a little bit later. I just want to share also, many people are just saying hello. So Isalmu from Mauritania sends his salam. Peace back to you, Isalmu. And let's go to the question on localization. And Kate, this is a sensitive one in a way, especially because of the success of immunization. Recent articles about immunization really highlight the urgent need to address setbacks in immunization, the need for a big catch-up, also achieve the impressive achievements of immunization, and just the number of lives saved is so impressive. But they tend to emphasize, we think, you may agree or disagree, the role of global agencies and donors in driving past progress. And so I'm wondering, what's your take on it? Is that the recipe that will work in the future? Why or why not? Is there a kind of immunization exception to what many in global health are discussing, the need to localize aid, to really have locally led action? A USAID, for example, is calling for a shift of power, decisions, funding from global agencies to countries, and also implicitly to health workers. What's your take on this topic? And what are we really celebrating? What does the future look like?
Nothing happens unless it's actually being driven from the most local place possible. Nothing happens unless the local community, the family, the parent is actually on board with what's happening. And of course, the long heard and long been part of the, nothing to us without us. And that is the sort of core central tenet of ethics in health, and of agency of individuals to really be the ones that are driving and deciding what they most want and what is most of value to them. So absolutely, and WHO is absolutely of this mindset that it is, the success is totally driven from the most local places, as low as you can go. And ultimately, that's about individual decision making. And where there is an important partnership is to assure that countries, communities, subnational districts, partners have all the support that they need, so it's not having to go it alone. We do know that resources matter, and we know that resources are scarce in many places. And so I think where the role of global entities, certainly donor agencies, comes in is to line up behind a country's plan, line up behind what a country most wants. And the best country plans are those that are driven by the communities that form that country. That's the role really of the donors and of the global agency, is to make contributions to that one plan that the country has, and to provide whatever assistance is requested by the country, be it resources, be it technical assistance, in order to be able to go as fast as possible for the ambitions that the country has.
We're going to go to Nduka Ozor to dive into climate change and health. But so in your, what happens if funders don't listen and support locally led action? How does it look different if funders focus on global priorities defined by the global north? What's wrong with that? After all, there's so many great technical experts at the global level. Why can't they just make the decisions and decide what's best for people in countries? What would go wrong if that was the model adopted?
Well, anything that's done without the fundamental interest, desire, and motivation of local communities is not resilient, is never going to stick. It's not going to sustain. The second thing is that it's just not principle-based. Communities know best what they most need, and that's the direction that should be taken. When we don't attend to those interests and those motivations, the funds that flow in are not funds that will end up with a resilient result, and it won't be a successful result. We hope all the time that global decisions, global agendas, are actually those that, what I like to call them, more worldwide agendas or worldwide decisions. They should be coming from the countries and from within the countries, from the communities. They should simply be representing what the world has decided is most important. And that means the full world, not just a small portion of the world that has assets. I think in immunization, many of the decisions have actually been very good decisions that have been driven by the greatest needs of the countries who most need the kinds of vaccines that are on offer. I think the question is, how can that be driven and owned much more locally for its implementation and for determining where the resources are most needed? I think there are very few vaccines that don't have a sort of underpinning of prevention, and especially optimum prevention in countries that most need them. So I think it's really about the resilience of the investments and whether or not those investments are going to affect the impact that the countries most want.
Great. Now let's dig in to the front line. Let's go to the front line of climate change and health with Nduka Ozor. Nduka, you shared this picture of northern Nigeria where you work. So not the picture on your screen, but the text you wrote. The combination of sort of what's fueling disease outbreaks, combination of low immunization rates, conflict, misinformation, poor infrastructure, and then you have climate changes in climate, extreme weather events, intensifying all of these issues like food security and displacement. And Nduka Ozor, can you first introduce yourself, and then we'll go to Kate to hear from the immunization perspective with that experience of EPI. What is her perspective on how to take on these kind of poly crises, is what some are calling them. And Nduka, please do introduce yourself.
All right, thank you so much. My name is Mr. Nduka Ozor. I am the project director of an NGO, community-based NGO, called Center for HIV/AIDS and STD Research. Currently, we are partnering with the former president of Nigeria, General Yakubu Gowon, who is also a goodwill ambassador on immunization in Nigeria. We work in the northeast Nigeria, where the crisis of Boko Haram has devastated and destroyed so many health systems. And what I wrote there is one of the observations we have made and we have seen. It is a critical situation in that part of the region. So I asked WHO, more especially, the regional governments do not have any form of intervention program apart from the 0 dose which they give to children sometimes, and then the vaccines are not even always available. The most of the activities there are done by foreign donors or local NGOs that have mobilized resources. So how can WHO respond to this? Thank you.
Thanks, Nduka. Before we go to Kate, another question that has come in, actually 2 questions from Lillian Mutua, who's watching on YouTube. So thanks, Lillian. There is a slight delay between when you send the comment and when we see it. So it says, why don't we have adequate resources for RCCE? So community engagement activities during emergencies, floods, disease outbreaks, but we have monies for commodities and supplies. And she says, we need local solutions to address vaccine acceptance, build community resilience, community-driven solutions using community engagement. So that's a lot there. And of course, it's not one department at WHO that can address all these different aspects. What's your take on how to, and what does the specific experience of EPI bring to the table?
Yeah, what an honor, first of all, to hear directly from you all in different settings in northern Nigeria, northeastern Nigeria. I have familiarity with the region that you're talking about. So a few things I'd like to say. First of all, I think one of the most important things that we can really understand is that there is no government, no agency, no NGO that can do all of this alone. I think at WHO we have a very, very deep respect, and that this takes all partners, all of government, all of civil society to address many of the questions that you're asking. And there are no simple answers to these things. But we do understand from a WHO perspective that we have some special responsibilities. And first and foremost, it's our responsibility to assure that governments, NGOs, community organizations are getting accurate information. And you referenced the misinformation that's out there, and especially misinformation about vaccines. And it's kind of heartbreaking, actually, to see where we are in the world right now. There, of course, has been misinformation about vaccines since vaccines existed. but there are means and communication mechanisms now where those small number of voices are actually given a huge megaphone, and unsuspecting community members who are otherwise trying to do the very best that they can for themselves and for their families are susceptible to these messages. So really getting accurate information and assuring that those who are in positions of responsibility have the information that is the basis on which good decisions can be made. And this misinformation costs people's lives. It's not innocuous. It actually results in people having information that stops them from getting vaccines, or decision makers impedes them from making decisions that would provide benefit to people. And I'll just point to a recent, I think it's spread quite widely, recent example in Uganda of some very deep misinformation. And I was very pleased to see a very strong statement from the government correcting the information and providing what is accurate information about malaria vaccine, about vaccines in general, and other matters. And the second thing that I would say is WHO's special duty is to provide every country, but especially those countries that are in conflict situations, not only with the information that decision makers can use in order to introduce and use products like vaccines, but also the very important communication with communities. And we saw throughout the COVID pandemic that communication from trusted sources of information is really, really critical. That doesn't mean necessarily it's WHO's voice, but it does mean that community leaders, whether they're formal leaders of communities or informal leaders, have access to information that they can share with their loved ones in their community to assure that people are responding in ways to health threats that will actually be effective.
Thanks, Kate. There's a natural tendency for discussions on these discussions on vaccination to veer towards the question of vaccine hesitancy. I take note of Charles Obiora, who's a hospital laboratory worker in Nigeria, who says, how do you address the vaccine hesitancy, especially in specific contexts? Before we go there, I want to ask just for an explicit, simple answer that can make sense, that can help immunization staff make sense of the changes they're seeing, of what is in front of their eyes in many cases. What does immunization have to do with climate change?
So many diseases that are affected by climate change are actually vaccine preventable diseases. We need new vaccines that are going to address new pathogens that are emerging as a result of climate change. We need vaccines that are deployed in places where those diseases didn't otherwise take place, but are now because of climate change. And thirdly, we need vaccination programs that have adapted to climate change risks and climate change impacts so that the vaccines that we do have can be deployed even in settings that are resulting in people that are displaced, people that are on the move, people that are in conflict, people who are malnourished, and all of those things are the things that are a result of climate change. And of course, there are more, but those are the three simple things that I would say.
Now, last July 2023, the Geneva Learning Foundation asked members of our global network questions about climate change in relation to health. 3/4 of the 4,700 people who answered are EPI staff. And we asked some simple questions. What are your observations of what's changing in climate? What are your observations about what's changing in health? And we ask, is climate change a threat to the health of those you serve? Why or why not? And amongst the folks who answered, not only were they primarily immunization staff, but they're also longtime members of local communities they serve, part of the family or trusted friend, as you can see here. And then when we asked this question, to what extent is climate change a threat to the health of the community that I serve? You can see the responses here from 1,234 health workers in 68 different countries, highest threat level for 606 of them. And when we asked, do you worry about climate change as a health worker? Again, we saw the highest level worry in so many of the respondents. Kate O'Brien, we also collected stories of change at an incredibly rapid pace causing damage to health in very immediate ways, and stories of health workers doing their best to respond, but doing it pretty much alone. How would you like to respond, and how do you think the global community, WHO and partners, can respond to this distress and to the sense of urgency that we got when we asked these questions and got such responses in return?
Right from the very most local level, all the way up to regional and global levels, attention is on this issue of climate change. At the most local level, the things that I think, first of all, you all know the best, not me, about what can be done at the most local level. But for me, the most local level is where the action really happens. So a couple of things I've seen some really good practices of. For clinic-based activities, we've seen some really good examples in flood-prone areas of doing some relatively modest restructuring of the clinic layout, so that equipment is in a safe place, is elevated off the ground, is not at highest risk of flooding out and destroying equipment and very precious supplies. Second is the program to solarize vaccine clinics and clinics that are providing multiple services. And obviously the ability to protect the electric access is really important, and solarization of facilities is a way also to reduce greenhouse gases. The third thing that I think we really notice is innovations that you all have made, especially in areas that are under severe climate threat, and especially very high temperatures, is really using a people-centered design around the services on immunization, because they're often delivering vaccines to young infants who are very vulnerable to extreme temperatures. The usual opening hours of clinics are not very adapted to extreme temperatures. And so we have seen some good examples where clinic hours are being adjusted to avoid having to bring children at times of the day that would be extremely uncomfortable, if not unsafe, for children. Those are some of the examples of the kinds of things at the very most local level that are in the hands, and you've got your hands on the levers of changes that can be made in order to address some of the climate change impacts that you may be feeling.
Thanks, Kate. So we have Wilfred O. Taikereweya, who has this question. He's from Liberia. Sorry, I'm asking him to unmute. And he wants to know how we can harness the One Health approach in expanding vaccination coverage and acceptance to communities in climate change situations. Wilfred, welcome. Can you tell us what you do in Liberia and what has led you to ask this question to Kate? That's also what we're interested in.
Yeah, thank you very much. I am working with the One Health platform in Liberia. I'm working as a data manager and an epidemiologist. So this question was brought up due to our vaccine coverage. It's mostly low during the rainy season. And then currently we are doing 2 vaccines. One is for animal health, that's the rabies vaccination campaign, and the polio. Therefore, we are experiencing low coverage as it relates to hard to reach areas where campaigners cannot go due to bad road condition, due to spottage of breaches, breach spoil, and rivers cutting roads. So how can we use the One Health approach to harness and expand vaccine coverage in those communities that are tough? What are some strategies will Dr. O'Brien recommend that we use to make those people get access to these activities and the vaccine services? Over.
What a great question. And you've described a setting that sounds really challenging, with physically inaccessible places, especially you're referring to the rainy season, washed out roads, really difficult accessibility. So I think actually one of the things that I think you're really pointing out is the innovations that we need. Some of them are here already, and I'll reference specifically areas of the world that are using drones. So Zipline is one of the examples. I think it just made its millionth delivery very recently. So although some of these are felt to be not scaled or not scalable, I think we have to be bolder in our thinking around how we can use technology and how we can use innovation to assure that supplies are getting where they need to be. Obviously, when roads are impassable, rivers are impassable, there are people on the other side of those rivers. They're merely impassable for those trying to get to those communities, but those communities are already in place and need to have access to services. So I think, first of all, we need to use better the innovations that we have at hand now. And secondly, we need more innovations. And I'll point directly to the microarray patches. So many of the vaccines now are injectable vaccines, which means that only trained health workers can be really deploying those vaccines in a safe and effective way. With microarray patches, which are effectively like a bandage, a Band-Aid that's put on the skin, although they're not completed in terms of development yet, we think these are going to be game-changing. And if we had microarray patches, even in settings like those that you're talking about, being able to deploy those vaccines, which really are the size of a Band-Aid, would really be transformative and would also allow community members, especially community health workers, and potentially even family members, to be actually doing the immunizing. If all it takes is to apply a Band-Aid for 5 minutes and then take it off and the individual is vaccinated, that is transformative in terms of the reach and the access to life-saving vaccines. So those are some of the ideas. I really wanted to bring in the concepts around innovation and what's coming down the pipeline and what in our lifetimes we are almost certainly likely to see. And I would say that probably in 10, 15, 20 years, we'll look back with kind of amazement at how impeded we are by the technologies that we're using today.
Thank you very much, Kate O'Brien. One final question for you. I'm going to share on screen, and I encourage you to go see the first Teach to Reach interview with Kate O'Brien. This was in January 2021. Obviously, this was a very special historical moment for the world as every immunization staff was getting ready to introduce these new COVID-19 vaccines and considering how to recover from the damage done wrought by the pandemic. I'm just showing here, this is Charlotte back in 2021, and of course Kate answering our questions. We've shared the link for those of you who are in our Zoom studio. Kate O'Brien, how would you measure what has changed in the last 3.5 years since you gave this interview?
Well, first of all, those of us who have the privilege of being in this conversation survived COVID. And I want to really honor, especially the health workers who didn't survive. And I really want to honor the health workers who, in the line of duty to deploy vaccines, have lost their lives. Many polio workers and others have had that tragedy. So that's the first thing I want to say is that what has changed over these 3 years is that we've made it through, the worst health event, the worst pandemic in 100 or more years. The second thing is that when this all started, when the pandemic started, one of the commitments that I think many partners made, certainly was made here at my department that I lead and WHO-wide, is that we had to assure that when we came out of this, we would be in better shape than we were going into it. And that is really partly true in immunization. There are technologies and practices that you all have implemented that went much faster than we ever thought were possible because of the infusion of resources during the time of the pandemic. And I'll point directly to things like using GIS technology, using digital mechanisms to actually monitor vaccination and track vaccinations, a lot of progress that was made in adult vaccination platforms and really introducing vaccination for adults, especially the elderly and health workers, to vaccination. So these were things that had long been talked about, but just didn't have the traction that we hoped that they would have. And many of those innovations have been sort of leapfrogged and actually are fully embedded now in programs in many parts of the world. I think the other thing that really changed is that we all discovered that when we work together and we work towards the same goal and we work with intention, that we can go much faster, much further, and with much more impact than we otherwise can. And so that really has been the seed of and the grounding of this theme that we're really inspired by, that it is humanly possible. And you can fill in whatever part of that sentence you want. It is humanly possible to get to measles elimination. It is humanly possible to get to polio eradication. It's humanly possible to protect all children against hepatitis B. It's humanly possible to give HPV vaccines to early adolescent girls to protect them from the future risk of cervical cancer. This is in our power to do. And it's humanly possible when we work together. And that partnership, the innovation, and the dedication that you all have, and that is supported by the global community, is humanly possible for us to get to the goals that countries, communities, families, and parents have.
Thank you very much indeed, Kate O'Brien, for your second and hopefully not the last Teach to Reach interview. Humanly possible indeed, ahead of the Teach to Reach conference, which is in just a few days. We've just shared the full schedule. If you haven't looked at this yet, I encourage you to do so now. Look at first of all, we'd like to bring attention and recognize all of the local and country-based organizations that are participating in Teach to Reach for the first time. As organization, we really recognize that locally led action and leadership, as Kate has said, is the key to solving many of the challenges before us. And we also acknowledge and recognize the global partners. We're going to get to the list here towards the top, including Gavi Zero Dose Learning Hub, the Vaccines Work blog, DevX, and of course UNICEF. A special mention for those of you who are from Nigeria. We're about to launch and announce the first immunization collaborative for the children and families of Nigeria. This is in support of the movement for Immunization Agenda 2030 in Nigeria. If you are from Nigeria, certainly we encourage you to check your emails, because we'll be inviting you to join this initiative. But first and foremost is Teach to Reach. You can go check out the full schedule. And just in case you haven't requested your invitation yet, over 21,000 health professionals from more over 80 countries have done this for this Teach to Reach 10. We'll be having a celebration of EPI at 50, and very much looking forward to seeing you for this occasion to celebrate. And we hope, Kate O'Brien, that you and others from the global community will be listening and learning together with health workers from all over the world. Once again, thank you, and not goodbye, but see you very soon. We're going to do a little rewind of the messages that we received during this session. I think because a third member of our trio is from Latin America, from Corrientes, Argentina, we're going to go with a little bit of a Latino melody, and just do a quick rewind of the messages today.